So, thank you, sir, for an excellent overview about the patient factors and the various instruments of blood pressure measurements and coming up of new gadgets. I have just one thing, that in medical college classical teaching, we teach them that not only the patient factors, but the consultant factor, when we are using the mercury sphygmomanometer, it should be at the level of the heart, and examiner also should be relaxed, and his eyes should be exactly at the level of the column of mercury which is moving. That is one. And second, how to calibrate the instrument. You have used the word validation so times, but how to calibrate the instrument?
Very good question. First, sir, I will like to respond to your first comment. Hope the mercury manometers should not be used. This is illegal to use them. In place of mercury, we can use the LED. LED. And you are very well saying that in LED what precaution we should make. For calibration was more required when we were using the mercury one. For LED, again, it is said that every 6 months calibration is required. For calibration, again we require the mercury one. They are calibrated against the mercury one. And for these monitors, no calibration is required. They can measure blood pressure 10,000 times. And when you have measured these values, they should be thrown away. The calibration can only be done at their manufacturer level. We don't have any calibration. For these.
Is there any correlation of the Doppler blood pressure measurement versus the instruments? Doppler indirect blood pressure measurement through the arterial Doppler.
Come again.
Blood pressure measurement through the Dopplers by radiologist and the calibration of the instrument.
That is one method, ultrasound guided method and Doppler method is prevalent. But when we have compared, again validation was not possible. So for clinical purpose, the Doppler one cannot be used. It is used only for research purpose. In my own study, we have done so many times, but only for the research purpose. For clinical purpose, still the Doppler one is not recommended.
No, not for clinical purpose, only for the validation, calibration.
For
calibration methods.
Again, for calibration, again, the only mercury one has been recommended, not the Doppler. Yeah.
Hello.
Thank you.
Yeah.
Thank you, sir.
May I ask one question?
Yeah.
Yeah. See that. See, the traditional definition of hypertension is blood pressure more than 140 or 90, right? But if you see the ADA 2024 guidelines for diabetic patients, new recommendation is hypertension only for diabetic patient is more than 130 by 80. So,
if you see, sir, I have mentioned in one slide, the value will depend what type of methods you are using. 140/90 was there only for the clinic blood pressure measurement. When we are using the different devices, then the values will differ. In diabetic population, the hypertension definition does not change. Only the target value change. And target value meaning by that, in diabetic we like to have blood pressure less than 130/80. But the hypertension definition will remain same.
no sir, the definition of hypertension is diabetes is different from 2024.
No, it is not different.
I
sir.
can show you. I'm just
you
showing
can
you.
show, but it is not different.
No, sir.
Because most of
It
the
is
guidelines-
2024. You see the ADA guidelines? I'm showing.
ADA has recommended that blood pressure should be done below this value.
No.
Hypertension value remains same. Hypertension
Okay, sir.
definition.
Because we are running short of time,
you can discuss.
you can
it
discuss,
separately.
off the stage.
I'm here only till evening.
Thank you, Professor Verma, for an excellent. You can ask afterwards. So now I invite Dr. S.S. Daria, my good friend. He's not there. Oh, sorry. Sorry, Dr. Sajid Ansari.
Yeah, Sajid Ansari.
So he will be talking on hypertension and CBD pathogenesis. Dr. Sajid Ansari is from Lucknow.
But we are not concerned about their vascular adventitia, intima and vascular endothelium, and what the condition of heart and their atria and ventricle. Anyway, you remember the normal cell of ventricle and atria, it is somehow, ventricle cell is thicker and is spindle shape and atria is a thinner cell. and ventricle is full of tubule. What happens when there is a hypertrophy of the cardiomyocytes? Cell get hypertrophied and muscle is thickened. If there is a hypertrophy in this smaller vessels and larger vessels, there are two important differences. In smaller vessels, this causes medial cross-sectional area remain normal, what is called eutrophic hypertrophy, where in the larger vessel, in the cardiomyocytes, especially in the ventricle, where muscle mass is high, not in the atrium. That's why hypertension causes atrial myopathy. This causes hypertrophic remodeling, where medial cross-sectional area is reduced and causes concentric hypertrophy. So this is the usual manifestation of this hypertensive heart disease. So we know if hypertension is there and BP is increasing, heart failure is a big element. I am not going to touch heart failure. This is all around and we are discussing it. So if there is increase in hypertension, what is going to change the vascular endothelium and what is changing the cardiomyocytes? So one thing, there is development of hypertensive heart disease. So what is that component? In the early phase of disease, if you see in the hypertensive patient, ejection fraction is looking normal, but the filling pressure is somehow dilated, and this the increase in tissue Doppler velocity and transmitral flow velocity. Either development of frank coronary artery disease, systolic and diastolic dysfunction. Systolic dysfunction, everyone I see your ejection fraction is reduced, but usually omitted by usually physician. No, grade 1 is mentioned, that is sufficient. Not that is sufficient. That the early changes going to happen in diabetic and hypertensive patient. And you know, HFpEF is the big entity now, and hypertension is a very important cause. Myocardial infarction, SCS, non-SCS, and arrhythmogenic complication. If you see the cause of lone atrial fibrillation in the hypertensive patient, maybe around 20-25%. And that's a very important supraventricular arrhythmia, atrial fibrillation, and that is an important cause of CVA. So development of arrhythmogenic potential in the atria is the important one. So when patient coming to pre-hypertension, he is having the risk factor, you think for how to act on this. You think for their kidney, you try to reduce hypertrophy. If you are not going to reduce hypertrophy, patient develop coronary artery disease, the kidney aspect develops CKD, systolic diastolic dysfunction and atrial fibrillation. That's the most commonest arrhythmia, and always think of it. And never, when patients start to develop diastolic dysfunction, that is the time you start to monitor their filling pressure and their condition of the atrial size. If atrial volume is increasing, ultimately this causes some shear force on the atrium, and that's the important focus for development of atrial fibrillation. This is some what happens if there is increase in blood pressure. There is effect on the preload. There is some mechanistic changes in this cardiomyocytes, and there is some changes in this afterload. So coming to afterload, aortic dilation, stiffness, and this arterial wall thickness. LA is a thin structure, so that's why you are calling left atrial, right atrial myopathy. In the ventricle, there is hypertrophy, either concentric or eccentric, but usually if patient is having only hypertensive heart disease, it is concentric hypertrophy, until unless there is secondary having CAD or some atretic changes in ventricle, this muscle is resolved, patient develop eccentric hypertrophy, and ultimately this lead to cardiac fibrosis and this hypertrophy. This is a way of left ventricular hypertrophy, how we are going to develop this left ventricular hypertrophy. There is a two-way in the hypertensive heart disease patient develops CAD. One is direct formation of plaque, and another important is if you see the data in the hypertensive heart disease, patient has not epicardial coronary artery lesion, but because of microvascular disease, patient have developed symptom of this ischemic heart disease and because of myocardial remodeling. Mechanism don't go, but truth is biochemical stress, shear forces, release of different kind of vasoconstrictor substances. Secondary is surviving myocardium after myocarditis faces on the skis in the diastolic wall stress. And thirdly, defect, genetic, everywhere the genetic defect is important, and sarcoma, cytoskeletal filament is there, and ventricular myocyte is full of T-tubule, and when the hypertrophy develops, there is a decrease in the T-tubule and ventricular myocyte get dilated. The impact is there are differences in the systolic and diastolic dysfunction, increase LV mass, and that's why this is important when you are reporting in the echo concentric hypertrophy. Try to mention LV mass and relative wall thickness or posterior wall thickness. This is the only way, that way you are going to say what the condition, how your patient is behaving. Regarding the ECG is not a very specific, The echo is the very basic tools to see the LVH, and because the ultimate, if your patient is having LVH, you try to regress the LVH, you try to reduce the filling pressure. So echo is the very important times. So you do it. This is a cascade of, this is one important data in the hypertensive heart disease, and left atrial enlargement was found around the 57%, LV hypertrophy in the 62%, LV systolic dysfunction, diastolic, and at the same time, you see the dangers. RV systolic and diastolic dysfunction also, that is usually omitted. So you need to focus on all the aspects of this things. Okay, so I am summarizing my talk. Just whenever you are getting patient of hypertension, forget what is today BP. Think of their what the condition of vascular tree, how to see. Go for some non-invasive and cost-effective investigation. Just you go see their intima medial thickness, pulse wave velocity, ankle brachial index, HSCRP level. In this way, you can make some image in your mind. You go for simply ECG, but ECG is not a very specific. You ask your cardiologist, go for cheaper rate in the echocardiography, mention their filling pressure in the early stage of disease. LSI is very important, then you can judge it. If it is 140/90 and my patient is having enlarged LA and high in filling pressure, why I will wait for the treatment? I will give some medicine to reduce the filling pressure. So, that's why I don't think this magic number. Yesterday it was 160/90 and today it is 140/90 and after to 130 and right now I am all right. This is not the way of measuring the blood pressure. Thank you, this is all from my side.
Thank you so much, sir, for that very interesting and crisp presentation. In the interest of time, we can probably have the discussion a little bit later. Questions can be entertained later. We will now go on to the next speaker.
Thank you.
Until the presentation is loaded, if anyone, okay, sorry, we'll go ahead.
We invite Dr. S.S. Daria, who is a governing body member of the APICC DSI and having the prestigious positions in the state and national bodies. And I request him to start his talk on secondary hypertension causes and how to approach.
Thank you so much, respected chairperson, for a kind introduction. And at the outset, I would like to thank Dr. Patni sir and team DRWA for inviting me here. So next into the ISH symposium, I will be speaking on the... It's not moving. Yeah. So I'll be speaking on the causes and when to suspect the secondary hypertension. As we know that hypertension is average of 2 or more seated blood pressure readings, already discussed by Dr. Verma sir. This is the British Hypertension Society, where we have the hypertension, pre-hypertension, systolic hypertension. So let's come to the primary essential hypertension. This term applied to the 95% of hypertensive patient where the elevated blood pressure results from the complex interaction between the multiple genetic and the environmental factor. The pathogenesis discussed by Dr. Sajid. So secondary hypertension, which is only 5 to 7%, and this should be suspected in patient whom hypertension develops at an early age, and those who first exhibit hypertension when over age of 50, or those previously well controlled who become refractory to the treatment. So the question was given to me that when we should suspect the secondary hypertension clinically. So in absence of family history of hypertension, patients coming less than 20 or more than 50 with the severe hypertension, more than 180 by 110 mm of Hg, hypertension which is difficult to treat or with significant end organ damage features, patient with combination of 4 P's, pain, palpitation, pallor, these are signs of pheochromocytoma. Person with a short and thick neck who is having a obstructive sleep apnea, polyuria, nocturia, proteinuria and hematuria, which is indicative of renal ill-movement. So in renal diseases also there is a secondary hypertension we have to suspect. In absence of peripheral pulses, brachiofemoral delay and abdominal peripheral vessel bruit, history of polycystic renal disease or palpable enlarged kidneys, we think about the secondary hypertension. Patient with the Cushingoid features, multiple neurofibromatosis, significant elevation of plasma creatinine with the use of ACE inhibitors, hypertension in children, history of snoring, daytime somnolence, obesity, which is indicative of OSA. So this is the causes of secondary hypertension which involve the drugs toxin. In renal disease, either it's a parenchymal which involve the polycystic disease, chronic glomerulonephritis, renovascular, renal producing tumors, primary sodium retention. In vascular, there is a coarctation of aorta. In neurological causes, you may have an intracranial pressure raise, porphyria, familial dysautonomia. In endocrine, you may have a hypohyperthyroidism, adrenal gland, probably because of Cushing syndrome, adrenal hyperplasia, primary aldosteronism, carcinoid, extraadrenal and exogenous hormones. Pregnancy, of course. In pregnancy, you may have a secondary hypertension, and because of stress, post-operative burns, pain, hypoglycemia, alcohol withdrawal and pancreatitis can also be a cause of secondary hypertension. So let's come to the one by one. In chronic kidney disease, it forms in whether it's a parenchymal or renovascular disease. In renovascular, the causes are mostly of atherosclerosis, Takaysu-arteritis, fibromuscular dysplasia. The most common cause of renovascular in India is the Takayasu syndrome, progressive aorta arteritis. In this, there you will have a para-umbilical brew, and there is a diastolic renal brew is more significant than the systolic brew. Proteinuria is a reliable marker of the severity of chronic kidney disease. Investigation, there is a moderate degree of suspicion in renovascular hypertension, then you may have a color Doppler, CT angio, MRI angio. Other tests may be a captopril screening test and interpretation of that. The digital subtraction angiography may be used in intraarterial injections. This is the DSA, which is showing the typical unilateral atheromatous renal artery stenosis. On this you can see here. This is the fibromuscular dysplasia before and after the PTRA, the atherosclerotic RAS before and after stenting. So these was the renal causes. Come to the endocrine causes. In pheochromocytoma, this is a chromophil cell tumor which is mostly adrenal and unilateral, and there is a 10% of rule. In 10% of cases bilateral, in 10% of all cases are familial, and 10% cases are malignant. There is a typical symptom of episodic hypertension, postural fall, pallor, throbbing headache. The palpitation and perspiration are suggestive of clinical features. They may be provoked by the triggers such as the tyramine containing foods, pain, trauma and drugs. Screening test, the urinary VMA, metanephrines, free catecholamines. The patient following drugs withdrawn after 40 years before doing these tests, alpha-methyl-dopa and beta blockers, clonidine and penicillin. These are the drugs which can cause false positive elevation in plasma and urinary catecholamine or metanephrine when you are suspecting the pheochromocytoma. So we have to see if a patient is taking all these TCA, the labetalol, the MAO inhibitor, the caffeine, levodopa and not. Tumor localization is done by CT MRI. The preoperative preparation and control of blood pressure is very important and can be achieved with oral phenoxybenjamin 10 mg once daily. Beta blockers may be given to these patients to control tachycardia and arrhythmias only after alpha blocker have been started. Next is primary aldosteronism. In this case, it is due to because of excess aldosterone secretion by the adrenal adenomas and occasionally due to the bilateral adrenocortical hyperplasia. Clinical pictures may be asymptomatic, headache, muscle cramp, polyuria, and in investigation, the PRA ratio more than 20 to 25. The confirmatory test is demonstrating failure to suppress the plasma aldosterone, and alternative confirmatory tests include failure to suppress the aldosterone in response to an oral sodium chloride load, fludrocortisone or the captopril. Of course, imaging techniques used to localize the tumor. This is the surgical removal of aldosteronoma, which can be done by laparoscopy. Next is the Cushing syndrome. The etiology behind this: pituitary microadenoma, heterogenic ectopic ACTH and adrenal adenoma. The clinical presentation, as we all know in daily practice, patient sudden weight gain, truncal obesity, moon faces, abdominal stria. For the screening test of Cushingoid features, 24-hour urinary free cortisol. Confirmatory test is with the low dose dexamethasone suppression test. Give 1 mg dexamethasone at 11 p.m. and draw a sample of blood at 8 a.m. for cortisol measurement. CT MRI of head to see the pituitary microadenoma or the chest to see the ectopic ACTH secreting tumors. Treatment, again, the surgical treatment is the main treatment where you have to do the adrenalectomy, removal of ACTH tumors. Next is coarctation of aorta. This may be a congenital defect. It is more prevalent in the male than the female. Clinical pictures, differential systolic BP in arms and legs, diminished or the absent femoral artery pulses, often asymptomatic. If uncorrected, then 67% will develop the LV failure by age of 40 and 75% will die by age 50. This is the coarctation of aorta, where you can see in X-ray you may see the inferior rib notching, and the definitive treatment is surgical. Then hypertension associated with the pregnancy. It is considered to be abnormally elevated and is associated with the increase in perinatal morbidity and mortality. In all pregnant women, the measurement of blood pressure should be performed in the sitting position, because the lateral recumbent position may result in a blood pressure lower than that recorded in the sitting position. This is usually caused by preeclampsia, chronic hypertension, gestational hypertension, or the renal disease. This is in preeclampsia and severe preeclampsia, there is a marked elevation of blood pressure more than 160 by 110 mmHg. There may be a HELLP syndrome where hemolysis, elevated liver enzymes, or low platelets may be the picture of HELLP syndrome. Estrogen use or oral contraceptive also may cause a small increase in blood pressure, which is mostly women are taking during their oral contraceptive. This is because there is a volume expansion due to the increased hepatic synthesis of angiotensinogen and consequent activation of the renin-angiotensin-aldosterone system. In postmenopausal estrogen, that does not generally cause hypertension, but rather maintains the endothelial-mediated vasodilation. Other important causes are thyroid disorder. It may be both hypo and hyper. Sleep apnea is one of the important causes for reversible hypertension. The polysomnography or the sleep study is diagnostic for that, and you can see that how much of the pause AHI score apnea is hypopnea index, and if there is a severe sleep apnea, the AHI is more than 20 or 30, then you may use the CPAP or BiPAP, which can improve your hypertension. That is why this is the reversible cause for secondary hypertension. Some acute stressful situation can cause intense sympathetic discharge and may temporarily induce the hypertension. Include the acute mental stress, hypoglycemia, intermittent porphyria, exposure to cold, burn, and the perioperative period, and post-head injuries. Drugs which can cause in blood pressure increase are the immunosuppressive agents like cyclosporin, tacrolimus, corticosteroid, NSAIDs, the COX-2 inhibitor, estrogen. Some weight loss agents like sibutramine and phentermine, ephedrine also causes increase in your blood pressure. The fludrocortisone, the antiparkinsonism, bromocriptine, MAO inhibitors, anabolic steroid like testosterone, sympathomimetic, pseudoephedrine, and stimulant like nicotine and the amphetamine. So all these drugs can cause increased blood pressure, or somebody is coming with the raised blood pressure, then we should take the history about their drugs, whether they are taking any drugs or not. These are the complications of secondary hypertension at the level of artery. There may be atherosclerosis, aneurysm, aortic dissection. In kidney, there is a CKD, cardiac failure, stroke, TIA. At the level of eye, there is a blindness. So, fundoscopy, which is a very simple, useful tool, which can be done in your OPD also by having only ophthalmoscope, which is a very essential part to examine of any hypertensive. And if there are any abnormality which is seen in your fundoscopy, this is being graded 1 to 4, and if there is a grade 3 or 4, then it is due to because of malignant hypertension. So this is the example of your fundoscopy, where you can see the malignant hypertensive retinopathy. In right one, you can see the multiple cotton wool spots, retinal hemorrhages, and swelling of the optic disc, which is visible on the fundoscopy. So to summarize, the initial assessment of hypertensive patients should include a complete history and physical examination to confirm a diagnosis of hypertension. Clue to secondary hypertension include onset at young age, abrupt onset of hypertension, blood pressure which is difficult to control requiring high doses of 2 or more drugs, and very high or labile blood pressure, headache with severe hypertension are occipital and worse in the morning. Thank you everyone for your patience.
Thank you, Dr. Varia, for giving an excellent overview in a stipulated time.
Thank you, sir.
It was very short actually.
Actually, I was given only 8 minutes, but I don't know why it was 12 minutes, so I kept it. Total 12 minutes.
So he has finished in time, so there is a time for a question. If somebody has any question, he can ask it.
Sir, you have discussed many causes of secondary hypertension. So, do you believe that the diagnosis of essential hypertension should be a diagnosis of exclusion, like diagnosis of type 2 diabetes mellitus, which is a diagnosis of exclusion?
Sorry, type 2 diabetes? Sorry, I could not get your answer.
The question is that he mean to say that diagnosis of primary hypertension should be the exclusion of secondary hypertension. I think this is the question.
Yes.
Yeah, so you want to say that the secondary, the primary hypertension should be the exclusion. As I told you that almost 95% patients are having the primary essential hypertension, only 5 to 6%, and this was my talk when we have to suspect the secondary hypertension. So once somebody coming with the younger age, less than 20 or the more than 50 with the uncontrolled hypertension, all causes I have already mentioned.
I think apart from the guideline what sir says, but any patient who is diagnosed to have hypertension for the first time, one can order the battery of the test to rule out the secondary hypertension. That is possible, and one should not miss to measure the blood pressure in all 4 limbs at the time of diagnosis.
Yeah, definitely.
Thank you, sir.
Thank you.
Secondary hypertension. Before labeling anybody's secondary hypertension, we must also exclude pseudo-secondary hypertension.
Yes.
Because of other causes, not these secondary causes which I have mentioned, patient may not be having compliance. And other causes, they are called as pseudo-secondary hypertension.
Yes. Thank you, sir.
So thank you, sir. Now for the next speaker, Dr. Rajneesh Saxena, who is from Ajmer and a senior diabetologist and food care specialist, and he is awarded in Medical Excellence Award in Diabetic Food Care by Deputy PM of Thailand in 2013, and Diabetes Awareness Achiever Award by Diabetes India in 2016, and RSSDI National Award for Diabetic Food Care in 2019. Over to Dr. Rajneesh Saxena, who is going to talk on algorithm for diagnosis and management of resistant hypertension.
Thank you very much, Chairpersons. I am very much thankful to Dr. Patni and team DRWA for inviting me for discussing this very important topic. Objective of today's discussion is to understand and discuss diagnostic algorithm of resistant hypertension and overview new therapeutic option for resistant hypertension. First of all, I will discuss one case. One 62-year-old female coming to you for the evaluation and treatment of difficult to control hypertension. Her BP is more than 140/90, in office for several times, drug history of hydrochlorothiazide, lisinopril and amlodipine 10 mg per day. She is complaining of occasional headache for which takes painkillers. She works as a manager in grocery store. On examination, BMI was 35 kg per meter square, heart rate 94, BP 164, systolic and 103 is diastolic. Pitting edema both ankle, and laboratory findings indicate that glucose is within normal and potassium 3.7, creatinine is also within normal range. So what will be the next most appropriate step in the management of hypertension? First, add metoprolol 50 mg BD, measure 24-hour urine-free cortisol, measure morning aldosterone concentration and plasma renin activity, measure fractional plasma metanephrine, review medication list including OTC medicines, advise to reduce sodium intake, increase weight reduction and exercise, and encourage to take medicine daily. Now I will discuss one by one. These classification already discussed by Dr. Verma, so I will not go into the detail. Not in the definition, as Dr. Verma already discussed that at present, according to ENHANCE and Framingham Health Study, only 53 and 48% patients are controlled after taking the medications. And if diabetic and CKD patient, only 25 and 37% are controlled and rest is uncontrolled. Similarly, in case of elderly patient, 40% is controlled. And in all these conditions, systolic blood pressure and diastolic both are different in controlling only 90 and 48 to 62% populations. These already discussed by Dr. Verma. So now I will directly approach to resistance hypertension. I will discuss first exclusion of the pseudo-resistance, second identification and reverse contribution of lifestyle factor, third discontinuation or reduce the interfering substances, fourth screen for secondary hypertension, fifth pharmacological treatment, last refer to hypertensive specialist. As exclusion of pseudo resistance is very important because only 12.2% patients having resistant hypertension, out of which 37.45% pseudo resistance and 62.5% true resistant hypertension. These are calculated by ABPM readings. Then pseudo resistance, already Dr. Verma discussed that poor blood pressure measuring techniques is very important to control. Second, poor resistance and white coat effects. For proper BP monitoring, always train your staff for proper reading taking, proper cuff using, and common mistakes. We already know that measuring BP without letting patient to rest and too small cuff, because doctors are very busy, so they are not waiting for 5 minutes. They directly go to measure the BP. It is very common mistake. Then less common is the acute effect of smoking, acute effect of coffee or wrist monitoring. Then poor adherence because the cost of the therapy and side effect of the medicine, complexity and organic brain syndrome because patient having loss of memory. So due to memory deficit, patient sometimes fail to take the medicine. Then white coat effect already discussed. According to office BP monitoring, ABPM and self BP monitoring, there are 140 by 90, 130 by 80 and 130 by 85. These different readings are recorded. So we have to, at the time of management, we have to keep all these things. Then identification and revert the contributing lifestyle factor, mainly obesity, more than 50% obese patients having resistant hypertension, then physical activity, physical inactivity, excessive alcohol ingestion, smoking, low fiber diet, females and ethnicity, mainly black people are at risk of developing resistant hypertension. Then effect of weight loss, if weight is reduced by 5%, then 5 kilogram, then there will be reduction in systolic BP 2.7 and diastolic 2.01. If more than 5 kg weight reduction, then 6.63 and 5.12 mm of Hg reduction is there. Then effect of salt restriction is also very important. Mean office systolic blood pressure reduction by 22.7 mm of Hg after salt restriction. Then medication, different medications can interfere with BP control, mainly non-narcotic analgesics, alcohol, oral contraceptive in female, and different other medications like erythropoietin and natural glucose and herbal compounds, mainly ephedra or mehung is also causing the rise in the blood pressure. These are the drugs, but aspirin in low dose does not interfere with the rise in BP, so it is neutral. Then skin for secondary cause of hypertension. Secondary cause of resistant hypertension are commonest are the obstructive sleep apnea, chronic kidney disease, renal vascular hypertension and primary hypertension. And uncommon are the pheochromocytoma, Cushing syndrome, thyroid, both hyper and hypothyroidism, primary hyperparathyroidism, aortic coarctation and brain tumors. So we have to measure, we have to check the screening for these secondary causes, mainly clinical history, physical examination, initially laboratory testing, mainly renal function test is important, very important. Then presence of risk factors should be excluded at the time of diagnosis. Then pharmacological management include antihypertensive drugs, mainly autoregulation by calcium channel blockers, hydrogen and minoxidil. If fluid overload is there, then we prescribe diuretics and humoral antihypertensives are the ACE inhibitors, ARBs, direct renin inhibitors and mineralocorticoid receptor blockers. Similarly, SNSR, alpha blocker, beta blocker, and alpha 2 agonist are also very important for management point of view. Then common treatment errors are the doses are too low because failure to titrate to effective dose, because patient generally miss to consult doctor regularly. They are coming after sometimes few months or few years and taking same medicine continuously. Then inappropriate antihypertensive drug combination, use of short-acting drugs, and failure to utilize diuretics. If EGFR is less than 40, then we have to start furosemide. Then BP and plasma lending activity is also very important. Lastly, device-based treatment of resistant hypertension. It includes the renal sympathetic denervation and baroreflex sensitization. Then lastly, special referral to the hypertensive specialist is very important. Indications to referral was refer to appropriate specialist for known or suspect secondary causes of hypertension. Refer to hypertension, especially BP, if BP remain uncontrolled after 6 months of treatment, and refer to hypertension specialist improve BP control in over 50% patients with resistant hypertension. Now, I conclude with this slide that uncontrolled hypertension and resistant hypertension both are not same entity, both are different. So exclusion of pseudo-resistance, implementation of lifestyle interventions, and discontinuation of the interfering substance are initial steps in approaching resistant hypertension. Workup for secondary cause of resistant hypertension should be reserved for patients with appropriate clinical clues. It is very important. Then referral to hypertension specialist can help to improve the BP control. Now, in this case, only review medication list is very important. Then advise to reduce sodium intake, increase 5 to 7% weight reduction, and exercise 30 minutes per day is very important. And always encourage patient to take medication regularly. Thank you very much. Now I invite.
Thank you, sir. Because of shortage of time, we'll move on to the other lecture. If any question is there, you can interact with the sir and the floor in the lunch area.
Okay,
Thank you, sir.
Now to the man of the hour, Dr. Vijay Patni. I think he needs no introduction. He is the scientific advisor, scientific committee chairman of this program, and he will be talking on the refractory hypertension, diagnosis and management.
Thank you all, and thank you for coming to this particular session. So we heard about probably the first one when we by Dr. Narsingh Verma about definition hypertension and about the grant study. Then we had insight into the causes of secondary hypertension, followed by management of resistant hypertension. Now, what is refractory hypertension? So this is extreme phenotype of antihypertensive treatment failure, and actually is a specific subgroup of resistant hypertension. This was first proposed in a retrospective analysis of patients referred to the University of Alabama at the Birmingham Hypertension Clinic, whose blood pressure could not be controlled on any antihypertensive treatment. So basically, these are the patients who were taken up into this particular, referred to this university, and thereafter this particular phrase of refractory hypertension came into it. So it is characterized by uncontrolled out-of-office blood pressure levels despite the use of at least 5 antihypertensive drugs, including the long-acting diuretics and mineralocorticoid receptor antagonists. Now, this is what Dr. Narsingh Verma sir was saying, that it should only be classified whether it's resistant hypertension or refractory hypertension only when factors which can influence the blood pressure like these can be ruled out, whether it's incorrect medication dosage, diet, probably not maintaining the proper diet as advised, and the white coat effect, alcohol use and smoking, because they are going to impact the blood pressure levels. Now let's look into the prevalence of this particular refractory hypertension. So if you look into the generally treated hypertensive patients, it's about 5.5 to 4.3%. But if you look in this resistant hypertension and try to look into the subgroup, it can range up from 3.6% to almost 51%. And then important is that if you look into the population which where we usually see is the resistant hypertension, the refractory hypertension associated with a younger age, African ancestry. Obesity may not be there. So they may present in the lean patients, and there is usually hypertension-mediated organ damage there. There could be a clinical cardiovascular disease and comorbidity like type 2 diabetes and obstructive sleep apnea. So when you look into the population of diabetes, it is seen that most prevalent among individuals with diabetes with estimated about 20% of the patient. So those who are diabetic, they are the one who might be having refractory hypertension. So the coexistence of these two important risk factors these risk factors which are there along with the comorbidity in individual with diabetes can further complicate the management of refractory hypertension. So both together obviously increases the cardiovascular complications. Now this is the pathophysiology which is actually attributed to the refractory hypertension, and the accepted mechanism is usually the chronic sympathetic overactivity. Then can obviously lead to increased vasoconstriction, enhanced renal sodium retention, altered baroreceptor sensitivity, and end organ damage. So again, there is a term which is known as pseudo-refractory, as the term is there, pseudo-resistance, and these are all, as I already described, wrong medication, wrong dosage, other medication which can interfere with the antihypertensive medication which are given for the patient, and again there are certain supplementation which probably the patient may not be aware of it, and they are taking it, that can lead to the patient having refractory hypertension. So all other factors are equally important, both for the resistance as well as refractory hypertension. So how do we evaluate the patient? Diagnose obviously by clinical assessment. Once you diagnose the patient at failure of 5 or more, including antidiuretic and the mineral corticoreceptors, then you have to clinically assess them. Obviously secondary hypertension dealt in length, so that has to be ruled out. And then the most important parameter is probably using 24-hour ambulatory blood pressure monitoring in order to define this refractory hypertension. Laboratory tests, you can do all of them, comprehensive profile, you can do it, and then you can look into whether they fall into the secondary hypertension. And then the most important is the imaging technique, which will give you an idea of how long this patient has been hypertensive, along with that, whether there is an end organ damage or not. Now, these are the secondary causes, already has been very well defined, and there should be appropriate testing before actually defining refractory hypertension. Now, when you like to look into the pharmacological management, apart from the non-pharmacological management, which will be there for all hypertensive patients, you optimize the therapy, then you add a mineral receptor, which we all did in resistant hypertension, but then utilize the newer agents, which probably are vasopeptidase inhibitors or endothelin receptor antagonists, which might work, but not still validated in these cases of refractory hypertension. And non-pharmacological management, mainly device-based therapies are important. So always consider device-based intervention like renal denervation or baroreflex activation therapy in select patients with refractory hypertension who are unable to achieve the target blood pressure. So this can be achieved. This actually can be used also in resistant hypertension. Then procedural intervention, including the carotid body tumor resection. If you can really identify them, that falls into the secondary hypertension. Then obviously, the most important is a multidisciplinary care. The cardiologist, nephrologist, endocrinologist all need to have their say, and a complex interplay during management is very much required. So if you look at the algorithm, this is the last slide of me. So confirm the diagnosis, confirm the high blood pressure reading, usually ambulatory blood pressure, assess the medical adherence, confirm patient adherence to the current medication regimen, rule out secondary causes, conduct the appropriate test as described. Then you have to really go for lifestyle modification for all the patient. Alcohol and tobacco need to be taken care of. Then optimize the current treatment, whatever the patient is on. So you have to optimize then go for advanced pharmacological strategies, use of combination therapies, use the newer therapies, and those can be used, and then continuous monitoring and follow-up, and then consider device-based therapy, and ultimately, most important is manage the comorbidities which are associated with. So this is in nutshell what I was talking about refractory hypertension. Now what we are going to do is, we will invite Dr. Narsingh Verma sir. Can you come on the desk please? Now we have a small quiz for educators and dietitians, whoever they are. And this is, the first 3 will be given some prizes. And this is a small 5 minutes job only. So whoever is going to answer first and correctly, which Dr. Verma is going to decide, he or she will be selected for the first 3 ones. So be ready, and can you brief it a little bit?
Yeah, thank you so much, sir. So I'll be briefing you all about the quiz. It's a quiz which is an online one. So you can use your phones to scan this QR code, and then the screen will appear which will request you to enter your name. So you can, as of now, just scan this code using your mobile phones, your camera, or your scanner on your phones.
Only for diabetic educators and dietitians.
Yes.
So Parag Rana, I'm sorry. Parag Rana, I'm sorry about that. You cannot do. हाँ, आप खाली audience देखते रहना.
25 players ready. Good.
Answer first to get more points. Mean arterial pressure depends upon cardiac output and peripheral resistance, arterial compliance, peripheral resistance. So it's noted on that computer, right?
Yes.
Okay,
yes.
so we don't have to worry.
Your names are being
Your
recorded.
job is done. Okay, I didn't know about it.
Yes.
Thank you.
उसमें आ
thank you.
जाएगा. And also,
So
if anyone
the
of
answer is cardiac output and peripheral resistance. I think most of them have done correctly. Can we go
Yes.
to the second one,
And
please?
also, sir, I would like to add, if any one of you wants to join, maybe if you were not able to join in the initial question, you can go to menti.com and enter the code which is displayed on the top. So you
Please
can
go
be a
ahead.
part.
Please go ahead. Yeah.
Yes.
Question 2. The basis of cortiscope sound is related to. Cortiscope sound is related to aortic valve closure, production of heart sound, arterial turbulence, arterial valve expansion. Parag sir, correct? So, unfortunately, only half of the people could answer this. Only five. Okay.
20%.
Okay. So we need to go back into physiology, which probably Dr. Verma can teach us. So, next question, please.
Yes, sir. So based on these two questions, this is the leaderboard.
चलो बस दो ही question है.
नहीं, we have 3 more questions to go.
पीछे बता रहे
But एक बार पता
बता रही है कि who is leading.
We don't have time, please.
Lower side is leading. Na? Lower side. Left side, sir. Left side. No lower.
Followed by snuggles.
Love always wins.
Anyway, let's see. The blood pressure measured by sphygmomanometer is lower than the intra-arterial pressure, is higher than the intra-arterial pressure, is same as intra-arterial pressure, is same with different cuff size. Correct answer you need to select. Okay.
Only 3.
Is lower than the intra-arterial pressure. Where is Somendu Ghosh? Where is he? We need to see where he is. Anyway, last question.
Sir, the second last.
Second last, okay.
Yes.
Spuriously high blood pressure is in all except auscultatory gap, small cuff, thick calcified vessels, obesity. Okay, so last question, and please catch hold of that gentleman wherever he is. True about the blood pressure measurement is all except cuff width should be 40% of arm circumference. Diastolic blood pressure is indicated by fourth. Cortiscope sound What is that?
Small cuff measures.
Small cup measure, spiritually elevated diastolic blood pressure. Last one is what?
Monkeyberg's sclerosis.
Monkeyberg sclerosis causes pseudo. Oh, they've all
5
answered.
people have answered correctly.
Okay, so this was the quiz. Thank you for participating, and we'll ask all the chairpersons and the faculty to come to the selfie zone. जीता कौन तभी अनाउंस करेंगे ना? हाँ बताएंगे, वो बताएंगे, हमें तो बताएंगे. Selfie zone, please. All the faculties of this particular session to come on the selfie zone for felicitation. Fatima,
Thank you so much, everyone.
Please. Okay. We go to the next session, and for that, I would like to call Dr. Parag Rana, Dr. Vinay Dhandania, and Dr. Puranjay Chakravarti to come on dais. I think two of them are missing, so I will request Dr. Akash Singh and Dr. Divya Saxena to come on the dais. And the speakers for this particular interesting session is Dr. Arvinda Jagdisha, Dr. K.K. Tripathi, Dr. Meena Chabda. You can't get better profile of the faculties than this. So, it's all yours, Chairperson, sir.
So we start this session. For this session, we have 3 speakers with us. First speaker is Dr. Arvinda Jagdisha. The topic is Omnius Octet and Beyond.
Okay, now please stand, because the names are such. एक मिनट लेके आओ ना उसको. Let's see how can we identify them. Okay, let's see. This first one.
Snuggles first.
Snuggles. Please raise your hand, Snuggles. Then love sight. Who is love sight? Please stand up. अरे भाई देखना तो चाहिए. Who is the one? And third one is very earthy person, Earthman. Who is that? Earthman. Snuggles, love side, Earthman, Dr. Pakka. I am sure Parag Rana is one of them. Okay, fine. So let's see. Okay, fine. So we go. Please, sir.
So we request Dr. Arvinda Jagdisha to start his topic. Dr. Arvinda does not need an introduction, I believe, so we start the lecture right away.
So, good morning, everybody. At the outset, I thank Dr. Vijay Patni and his team for making me a part of this conference. So, today I am going to talk on an topic, Omnius Octet and Beyond. So since past 25 to 30 years, we are discussing about this particular topic, and we have gone beyond that. That is the main thing. So I'll go refresh your knowledge and go beyond that. So first of all, greetings to all of you from Bangalore. So from the triumvirate to the Omnius Octet, a paradigm for the treatment of type 2 diabetes. It all started with the triumvirate. Like way back in 2009, DiFranzo stated that the 3 main things, that is for type 2 diabetes, 3 main pathophysiology for type 2 diabetes is impaired beta cell function, increased hepatic glucose, and insulin resistance. So in 1987, DiFranzo described this triumvirate of beta cell dysfunction, muscle and hepatic insensitivity to the glucose lowering effects of insulin. It was postulated that insulin resistance at the liver contributes to fostering hyperglycemia in the early stages of type 2 diabetes. Beta cell dysfunction and insulin resistance at the level of skeletal muscle promotes hyperglycemia in the post-absorptive state, a defect that is demonstrable on the standard oral glucose tolerance test. Next comes after the triumvirate. Professor Tripathi sir is there. I am sure morning we had a discussion about the various aspects of the past thing. One of the important aspects was about the diabetes pathogenesis. Next, after the triumvirate comes the disharmonious quartet, that is the bad tune for diabetic patient. So you can see in this slide, that is the adipocyte dysfunction. Like if you see in this slide, on the left hand side top, you can see the normal adipocyte. When there is an excessive energy intake, there will be hypertrophic adipocyte. On the right hand side you can see, leads to impaired lipid metabolism, altered adipokine secretion, immune cell infiltration, inflammation, insulin resistance. Then comes down, you can see lipid spillover, systemic inflammation. Then there will be lipid accumulation, inflammation, and insulin resistance. This is the function or dysfunction of adipocyte. So the disharmonious quartet is the triumvirate plus adipocyte dysfunction. So what is adipocytes are resistant to anti-lipolytic action of the insulin. This leads to increased liberation of free fatty acids in the fasting state. Excess circulating free fatty acids promote hepatic gluconeogenesis, hepatic insulin resistance at the level of skeletal muscles, and impairs insulin secretion. So dysfunctional adipocyte produces an excessive amount of pro-inflammatory adipocytokines like tumor necrosis factor, interleukin-6, resistin, and angiotensinogen at the expense of more insulin-sensitive adipocytokines such as adiponectin. Next is the quintessential quintet, that is disharmonious quartet there plus the incretin effect. Like past decade we are seeing this, the various discussion happens about the incretin effect. So we all know in type 2 diabetes, the status of incretin effect you can see in this particular slide, it is reduced. So what is that quintessential quintet acknowledges the contribution of gastrointestinal tract in the pathogenesis of type 2 diabetes. And oral glucose load stimulates the more considerable increase in insulin secretion compared to the intravenous glucose bolus. Indeed, the incretin effect occurs as a result of two critical peptide hormones secreted by the digestive tract, that is the GLP-1 and GIP. GLP-1 secreted by the L cells of ileum is woefully inadequate in patients with type 2 diabetes. GLP-1 is therefore unable to inhibit the secretion of glucagon. The GIP secreted by the proximal small intestine, on the other hand, is increased but is unable to mediate its target organ effects on the pancreatic beta cells. Next comes the cetaceous sextet, that is the quintessential quintet plus hyperglucogonemia. The pancreatic alpha cell dysfunction leads to significant hyperglucogonemia in the fasting state. This is an essential cause of fasting hyperglycemia. You can see in this particular slide, the area of alpha cells is increased in type 2 diabetes mellitus. Next is the septicedial septate, that is cetaceous sextate plus the altered renal glucose handling. This led to the blockbuster molecule. So we all know that is SGLT2 and SGLT1 transporters present in the proximal tubule of the kidney reabsorbs all the filtered load of glucose in the proximal tubule. This effectively prevents glucosuria. Interestingly, the upregulation of SGLT2 transporters due to chronic hyperglycemia leads to maladaptive state in which glucose preservation further aggravates diabetes. You can see in this, I am sure all of you are quite aware of, because last 1 decade we are discussing about this particular pathogenetic aspect. The ominous octet, the last one, is perhaps the most important, that is player to be implicated in the pathogenesis of type 2 diabetes is the brain, which makes the ominous octet. So ominous octet is septicidal septate plus the central nervous system dysfunction. You can see in this slide the 8 ominous octet proposed by DiFranzo. So, ominous octet of type 2 diabetes mellitus was proposed by Rolf DiFranzo. It encompasses 8 pathophysiological perturbations underlying the onset and persistent of hyperglycemia in type 2 diabetes. The appetite suppressing effects of insulin are significantly impaired in type 2 diabetes. Functional MRI studies have demonstrated dysregulation at key hypothalamic centers responsible for appetite suppression. You can see in this slide the ominous octet illustration and type 2 diabetes pharmacological therapies and medications. This is a very interesting slide which shows the ominous octet and the various drugs available where it acts, like SGLT2 inhibitors, DPP4, metformin, glitazone, and GLP-1RA. You can see GLP-1RA addressing the almost 6 of the 8 pathophysiological aspects of type 2 diabetes. So you can, in a gist, you can see in this slide how the things happens. On the right hand side, you can see how the alpha cells and the beta cells ultimately contribute in the development of hyperglycemia in type 2 diabetes. So treatment aspect as well. We know the pathophysiological aspect. In the same way, the newer molecules have come into the picture. The good thing of diabetology is the various pathological, physiological we are understanding, and accordingly the newer molecules are coming into the market, and which is very, very a big boon for our patients with type 2 diabetes with so much of evidence-backed medicine. So the summary of ominous octet is, you can see on the left hand side is the traditional triad, on the right hand side is the ominous octet. So multiple drugs in combination required to correct multiple pathophysiological defects. The treatment based upon reversible of known pathogenic abnormalities, not simply on reducing HbA1c. Therapy started early to prevent slow progressive cell failure that already is well established in impaired glucose tolerant patients. Now coming to the beyond ominous octet, that is after 8 reasons, now we have got 12 reasons, that is we call it as dirty dozens. So the addition of 4 well-known hormones to the list of players in diabetes to bring the number to 12. All 4 hormones have adequate biochemical, epidemiological, observational or clinical support to merit the inclusion in the list of dirty dozen of diabetes. That is catecholamines including dopamine. Patients with type 2 diabetes probably have an early morning dip in the dopaminergic tone leading to an increased sympathetic activity and thereby increased insulin resistance in the morning. This perhaps explains blood glucose excursions being significantly higher at breakfast than at lunch and dinner. The therapeutic role of catecholamines, administration of bromocriptine, a D2 receptor agonist, mediates a decrease in inappropriately elevated hypothalamic non-adrenergic and serotonergic levels, with the resultant decline in hepatic glucose production and adipose tissue lipolysis, therefore improving insulin sensitivity. Very important, always discussed in any forum. Last week also there was a discussion about the vitamin D and its role in both type 2 and type 1 diabetes. It acting as an immunomodulatory hormone, decreases pro-inflammatory cytokines, increases anti-inflammatory cytokines, reduces autoimmune insulitis, and protects against type 1 diabetes in children exposed to high doses of vitamin D in utero or in infancy. In adults, vitamin D is linked with both insulin secretion and insulin sensitivity, and there is a strong body of evidence which justifies its inclusion in diabetes dirty dozen. Testosterone is postulated to import a profound effect on insulin sensitivity, and its deficiency alters several metabolic parameters linked with the emergence of type 2 diabetes. The third National Health and Nutritional Examination Survey found that men with low free testosterone tertile were 4 times more likely to have a type 2 diabetes than those in the highest free testosterone tertile. So this is the beyond ominous octet. Now comes the dirty dozen. Now the 13th one is the Tricarius 13. It is called as Tricarius 13, that is iron. The more understanding is happening in the field of diabetes. From 3 reasons to 13 reasons we have come, where iron is one of the reasons for the pathophysiology of type 2 diabetes. You can see in this slide iron metabolism in regulating insulin secretion in beta cells. It looks a busy slide, but it tells about the various aspects, how much iron is important to our body, especially if you take in our country where iron deficiency is very common, whether that is leading to the onset of type 2 diabetes, especially in ladies. So we have to keep an give a thought about this in correcting anemia from the beginning of the lifespan, especially in the ladies. So from dirty dozens to sweetening 16. So that is another important three reasons to be considered. So you can see in the sweetening 16, this is a gist of all the pathophysiological reasons which we are coming to the picture and which we are understanding more and more. You can see from skin, adipose tissue, kidney, skeletal muscle, brain, testis, liver, alpha cells, beta cells, and the intestine. So all this together constitutes the sweetening 16.